All right, so I was asked by Taylor to come up and give a presentation for your Primary Care Week. I think originally somebody that I work with on the Missouri State Board was asked and she wasn't available and gave me the lovely recommendation to come up and do this talk for you guys. And I hear that maybe some of you guys are really interested in the business end of medicine. Surprising, most of you, are you first and second year students? Yeah, I didn't think about this stuff at your age by all means. And so it is an important part of medicine, but I'll say it's also kind of a boring part for most people because we get in here and we want the clinical practice and the research and this and that, but you can't practice if you don't have all this other stuff going on, the business side, as we say. So that is the topic, and so I apologize if it gets a little bit boring, but if you have any questions along the way, just give me a holler. She already gave that. This is just a bit of an outline, the different things that I kind of chose. This is a topic that can be very wide range, and I just kind of picked some things to talk about. And so I didn't have this presentation ever before. This is the first group I'm giving it to, so it's not a cookie cutter presentation. So I kind of put it together with some things that I thought would be beneficial. So one of the first things is just talking about the different models of practice, some pros and cons of what types of practices you can go into, as well as the practice emphasis in family medicine, because family medicine is pretty wide range options of what you can do. You guys already know that. Breakdown of some family practice statistics that they have out there and surveys that they've done to kind of tell you where people have gone with primary care and what direction they've gone in. Some of the reimbursements in medicine, as well as payment management opportunities, and the lovely electronic health records, which for you guys will be a completely different world than my time, Dr. Wilson's time. So during my training, there was no electronic medical records up here in Kirksville. A couple of the local physicians had them, but by all means, we were not trained on anything in medical school. And that was not, I'd like to say not all that long ago, but it keeps getting further out. So anyway, that is something that's definitely not going to change, but we have a lot of room still for improvement in our electronic health records. So just kind of the same thing here, learning objectives, just identifying the different primary care models in practice, as well as understanding what the broad scope is and how you could really tailor family medicine to what you want it to be, which I think that's a fun topic in itself. I don't know what you guys have all had this week, but just the broad scope of family medicine, it's what makes it fun. The several different types of reimbursement and then the benefits of the EHR system. So as far as the different models in practice, you have this is just kind of a generalized, you have your private practice, or you can be employed, or the newer model in the last 10 years or so is the direct primary care. Do you guys learn a little bit about what direct primary care is? You guys talk about that. I don't know if there's anybody up here in Kirksville really doing that. Maybe Dr. Hardin's practice is a little bit like that these days, but to an extent. But anyway, Macon, of course, we only have our employed group by the hospital and one private practice, and then your guys' health council has a group down there. So direct primary care is getting pretty big in bigger cities, not so much out here in these smaller towns, at least not yet. So with private practice, there's a lot of ways you can go about private practice. You could have a solo physician working by himself. I go to the state meetings quite a bit since I sit on the board. I don't find too many of these left anymore, but there are some. We have one in Macon. You have group practices. You could get, a small group versus a really large group practice. And, a lot of times the multi-specialty groups are going to be in the larger cities where you might have internal medicine as well as family medicine, as well as, maybe a cardiologist, all kind of within the same system. A lot of times those type of multi-specialty groups end up falling more under an employed by a hospital, but you could still get some of those in private practice. And then, of course, for us up here in Kirksville and Macon, rural practice, pretty big part in medicine and trying to make sure everybody has access to health care, because a lot of that does fall into our rural areas. Employed, we'll talk a little bit about this. This is kind of where a lot of people have gone. mostly because of the way the EHRs and the costs of those and a lot of the different governmental regulations on medicine. It makes it hard to be in private practice. So a lot of people have moved to the employed. You can be hospital-based. I'm hospital employed, but I have a clinic base, so I'm not really in the hospital. So there's, the couple different aspects like that. You can have community health centers. Once again, the multi-specialty groups, you find them more in the larger cities. And then, of course, the rural practice. And then direct primary care is a form of a private practice, but different enough that it deserves its own topic. So once again, and I'm going to have to move this way because my colors are pretty bright or pretty light. Private practice, these are just some statistics. The problem with some of these statistics are different groups send out surveys and they expect, the family physicians to return those surveys. And I don't know, are you a physician? Because you smile at a few things, I'd say. Manage a practice. And so, we're so busy that, I delete a lot of emails and a lot of them are surveys. So I'm going to admit that I don't fill out these surveys like they would like us to. So the statistics that we get can be a bit skewed because it's only a small percent of people who actually go out. But in one of these surveys back in 2007, they were suggesting about 33% of family physicians were actually in a solo practice. And that, as of 2017, is down from 33 to 11%. So we're really losing our solo practice family physicians. 2017, in the review of physician recruiting incentives states, so once again, another survey said that in 2014, 11% of physicians were in employment by a hospital, and by 2017, it went from 11% up to 47%. So once again, even these individual practices, there are a lot being bought out by the hospitals. And then the hospital ownership of physician practices increasing to 86% from 2012. And then there's saying that they've acquired about 31,000 physicians. That means hospitals buying up these private practices and stuff. As far as private practice, of course, there's pros and cons. The pro is you are your own boss. So if you're a hard, most of us are, strong-willed people to get where you're at. But, some people just have that boss mentality. I don't want to be told what to do. I don't want someone micromanaging everything I do. And you have to have a bit of a business background to do this. But, that's the biggest incentive. You are your own boss. You set your own rules. You're not told what to do. And so you're also not told how many patients do I have to see in a day. Your paycheck is not based on X, Y, Z. And so that's definitely some of the pros to staying in your own private practice. Cons, if you're in a small group or a solo group, call coverage. You can't really provide call to your patients very well if you're the only one there, okay? I'll use an example of the solo practicing physician in my community. He does have one nurse practitioner, but he takes his own calls, and he is the doc from way back in the day. He gives his patients his cell phone number. Do what you want, I won't do it. I won't accept him on Facebook. I keep my private life and my physician life separate. But yeah, his patients just call him on the cell phone. If they're heading to the ER, they call him and he meets them there. And so some people do still practice that way. But call coverage becomes a problem. When he goes out of town, he asks our group to cover for him. And we're fine to do that because we're a small community and we work well together. The other cons, overhead charges. When you're in a group, you definitely can have people share, the staff and everything. The electronic records, which is down a little bit lower, is very costly. And so when you're in a group, you can share that cost across the board. Personnel issues, when you're in a private practice and you have one nurse and one person up front and they have an issue and they're arguing whatever, in a practice like I am, I don't deal with that. If my nurse has an issue, they go talk to the boss. I don't have to worry about that. I go in and take care of my patients, and any of the drama that happens is not my issue. And then ordering of supplies, something simple, but when you're having to provide your own printer, your own desks, whatever, in a private practice, that does get to be costly. So those are just some of the cons. As far as being employed, there's lots of pros and cons to go with that too. A pro, you know what your paycheck's going to be at the end of each pay period. There's really no uncertainty. You sign into a contract, whether it's a 1-year or a 3-year contract, and you know what your dollar amount is. The part that can vary is a lot of them have bonus structures. And so the bonus structures get varied on different, it depends. Like our bonus structure has 4 different things that we have to meet in order to get a bonus. And you might get 25% or 50 or 75 or 100% of your bonus, depending on how much of those 4 you meet. So the good thing is you don't have an uncertainty. You also don't have to worry about administrative headaches. Hospitals worry about the HR issues and all that stuff, okay? And so that's something you don't have to worry about, you know, collecting billing and payment and your rent and your overhead charges. And oftentimes income can be higher. This really varies. I've read a bunch of different statistics on it where income may be more considered higher here, but also I think it comes with your benefit packages that you can get by being employed. When you're self-employed, you have to provide your own insurance and stuff like that, but employed by a hospital or a large group or something, they're going to give you benefits for health insurance and stuff like that. Typically, you can have more predictable work hours. You know, if you have other people working with you and you're employed, you usually have your set schedule. We start at 8 o'clock, our last patient's at 4 o'clock, and you kind of know that. If you're not in a group like this, then a lot of times you're just having to see your patients when they need to be seen because you're the only one there. Opportunity to influence larger organizations. So if you are working in a large group, it a lot of times is easier to become involved in the community through that group and to work together as an entity with them to hopefully help make some changes in the community. Definitely there's some cons to go with everything. You're not in charge. There's a lot less clinical autonomy. Once again, you're told what to do. Compensation can change, especially depending on what kind of system you're based on. You do have to re-sign that contract. You never know. They might find somebody cheaper. This day and age, they might find a nurse practitioner and say, you know what, we don't need you. We have, you know, somebody that we could pay a lot cheaper. So there is some, you know, concerns with having to re-sign contracts and not knowing if your job's going to be there and what it's going to pay you. There's also a lot of cons that hospitals are judging you by your metrics and different things that you may or may not be meeting for quality measures and stuff like that in order to give you your bonuses and stuff like that. Newer technology, you don't get to choose. We have no choice. I'm asked to sit in on these, take time out of my day to go sit in on these demonstrations right now because we're looking at new EHR. And I sit there and I ask my office manager, I'm like, why am I here? Do I get a choice? Well, no, you really don't, but we want your input. Okay, so you don't. I have no say in what EHR we might go to. I don't know why we have to change. I like ours, but anyway, physician turnover is also a big issue for groups because a lot of times people, especially right out of practice, they're not necessarily really tied to that. They just get a job and then they end up finding something else and they move on with their contract. They don't feel as connected when they're just employed. So physician turnover is a big thing. Direct primary care, as I said, is a newer kind of model and practice that gets a lot of talk about. You're able to maintain your independence through direct primary care, otherwise sometimes known as a concierge form of medicine. And basically here, third-party payments are eliminated. So you're not taking Medicare, you're not taking Medicaid, you're not taking private insurance. What these physicians are doing is typically charging patients either a monthly or a yearly fee, and sometimes quarterly there. And basically that fee, they can come see you 10 times a month or they can come see you twice a year. It's whatever they need. And so whenever they need to get seen, they just call and they get set up. They include in those fees some of the basic labs and everything like that that they may need, or special testing, x-rays, whatnot. The pros to this is there is a decreased practice overhead because they kind of can limit the amount of people they're seeing. They're not reimbursed by Medicare, Medicaid. They don't have to follow all the rules and stuff that we have to in order to be reimbursed. They have improved collection rates. You pay me or you don't get seen. And so it's an upfront cost for them. And so they know what they're going to get. They tend to have more time with patients. I think later I have somewhere around 30 minutes to an hour per patient. And so that's excellent. And the reason for that is because they tend to run about 600 to 800 patients in their panel versus an average family physician of at least 2,500. There is the pro of not having to deal with insurance companies. Okay. Cons, increased responsibility of the patients to manage their care. So these patients oftentimes are encouraged to get some sort of a secondary plan to cover emergency costs. And sometimes with that, they can take their information from a visit and turn it into their insurance, but that's all up to them. This office is stepping out of it. They say, you know what, if you want to have insurance and also be a member of our team here and be one of our clinic patients, that's fine. You can have insurance. They're not saying you can't, but you're going to file your own billing for it. So most patients that I deal with can't probably really do that very well. So the hard part here is also recruiting new patients. It's not an easy task. So if you come out of medical school and you go straight into direct primary care, you need to build up somewhere between 600 to 800 patients. That takes a long time. But that's what it takes in order to make it a cost effective. Otherwise, you're losing money up until that point. So I was on a forum with some other physicians, and there was a new person in practice in direct primary care. So they had to get a loan to join into the practice, and they had 6 months, I think it was, to build their practice up that they would not, deduct from them. But after that, they were on their own to cover their costs, and so this person was asking for another private loan because they hadn't met their patient numbers yet. And the startup costs along with that are really, really high, the startup costs. So direct primary care versus traditional doctor visits. This just kind of gives a little bit of breakdown from one of the surveys. As far as this survey goes, they say about 80,000 almost medical professionals are practicing family medicine, and there's about 1,000 in direct primary care. That number is going to be changing all the time because this is a pretty popular model that they're going to. Here it says, on average, 2,367, 2,500 patients. Once again, 500 to 1,000. As far as the cost per visit, this is going to, in a regular family medicine, depend on your insurance plan, but here oftentimes it's about $50 is what they gather per visit or a monthly membership, and it just depends. Each practice for direct primary care can make their own costs. Visit time about 13 to 16 minutes versus 30 to 60 minutes. So patients like this. They feel like they get listened to. Salary, there's a lot of different variants, and I have some more slides on average salary, but this group just says about $200,000 for family medicine, but this one is just paid monthly with your reimbursements, and so it just depends on how many patients you have and what your practice is set up as. This says, can you use insurance? Yes, you can use insurance here, but you're not dealing with it, so it's not like you can't have insurance and be in a direct primary model. Then blood tests, once again, you're filing it to insurance when you're in a practice. When you're in direct primary care, it's just part of your coverage. And then as well as medications. Your medications come from your direct primary care offices generally. They keep a stock of different things. So moving on to a new topic, practice in emphasis in family medicine. So you guys probably are all pretty aware that in family medicine, the wonderful thing about it is you could kind of choose your path that you want to do in family medicine. You can, do public health. You can do pure hospitalist based that you see a lot in the rural towns and stuff. You can stick with emergency and urgent care. You can go more into the education system like Dr. Wilson here, sports medicine, maternity care, research, nursing homes, procedural medicine, international wilderness medicine. There's just a ton of different things that you can go into. These are some of the actual fellowships, not inclusive to everything, but just some of the fellowships that you can go out and get extra teaching and certification in adolescent medicine, of course, osteopathic manipulation. We have that residency extra year here. If you are in family medicine, you can get emergency medicine and urgent care, faculty development, geriatrics, hospice. So there's a lot of different things. Obstetrics, you can go off and get a whole extra year of just obstetrical training. As you probably all know, that there's even some family medicine residencies that you're going to learn C-sections in, so that you can do the full scope of practice there with women's health and OB. There's, of course, research paths that you can take as well. So there's a lot of different options there. As far as public health, I think you guys, I heard you had a National Health Service talk yesterday or panel, just kind of some of the reimbursements to be able to go out and practice medicine in certain areas and get some of your student loans paid off, which I'm not sure what year I predict to pay mine off, but it's still a long way away. And that typically is going to place you in certain underserved rural areas, as well as the Indian Health Service, which they say there's about 557 federally recognized tribes in the 35 states, and so putting you out into one of those communities. There's hospitalist inpatient medicine. As family medicines, we have the most unique set of skills in that we can treat anybody from a pregnancy to newborn care up to the elderly. And so we're trained across the board versus at our hospital, there's our hospitalist system that we've made up is my clinic. A few of the people take turns for a week on at the hospital. I don't do it anymore, I used to. But one of them's an internal medicine doctor. And so when she's on, we kind of come into a problem if we have a pediatric that we want to admit for, whatever reason, flu, virus, whatever, they need some fluids. And so whenever she's on, one of us other physicians have to go and take care of that. So that's the great thing about being hospitalist in family medicine is you could take care of everybody. Some physicians do choose to do this full time, others just do it on a part-time basis. It says more than 66% of family physicians still have hospital privileges. That doesn't mean you're actually going to see hospital patients. I have hospital privileges, but I don't do inpatient work. So I could, and if I don't know if somebody that I really wanted to see was up there, I could definitely see them. They don't prevent me from going to do my own patients up there. Emergency care, urgent care, similar, you could just choose to exclusively do that. Is Dr. Burby a family medicine trained? And he only does, emergency medicine. We have most of our physicians that work down in Macon are family medicine physicians as well. You can go the education route where you join the school as a faculty member. Okay. Sports medicine, there's definitely sports medicine fellowships, and a lot of people really enjoy taking on that role, especially if they have a background of a lot of sports. Of course, family medicines are well, especially us in osteopathic world, well suited for this as we understand the musculoskeletal system a bit better. And then, as I said, the maternity care. This is essential in some of the underserved areas for us in Macon. Patients either come up here to deliver babies or they go down to Columbia. We're fortunate enough in our clinic, they used to deliver in Samaritan, but in our clinic, me and another provider, we both do prenatal care. And so we'll see patients up to about 36 weeks. We get to do all the fun stuff of, doing all their prenatal care. And then they go and deliver somewhere, and then they come back with their baby, and I get their baby in the practice too. It keeps my practice young by doing that, meaning I raise a lot of kids through my practice, and I get a lot of young women in my practice. And so I really enjoy that. And so me and the partner that I work with both have a lot of young women and children in our practice for that reason. Research, so a lot of family physicians may be asked to just collect data. Like I could work down full-time in Macon and then be asked to participate in a research project. And so that's some of the ways you can get research, or you could go full-fledged into research. Nursing home, a lot of us in rural areas, we have to take care of our own patients in the nursing home. So for our clinic, there's a few of us that go to the nursing home, and I do that. That's what I did before I came down here. And then a couple of the other physicians, they choose to do more on the hospital side, and so they still have clinic and they do more of the hospital work. So we kind of divide it up and take care of all our nursing home patients. Procedural medicine, I love this part of family medicine. You could do as much procedures as you want to for the most part. You can go and get special course training in procedures. That could be anything from births to circumcisions to dermatological procedures, mole excision removals, cryo, different things like that. Colonoscopies. My training up here, being in a rural hospital, I was able to get colonoscopy training in EGDs, and so I do those down at Samaritan Hospital too. And I think if I was at St. Louis University or some larger city, you wouldn't get this. There's too many GI doctors and surgeons down there. International wilderness medicine, so that's just a unique approach to medicine, and being able to go out and practice, and a lot of mission trips and stuff like that are really good to have this bit of a background, because you just don't know exactly what you're going to get into. I believe it was Dr. Cleaver has talked about doing some mission work where they literally get on a catamaran and they sail down a river and they hop off and they go into the woods and they go to little tribes and they take care of people and then they sail further down. Isn't that Dr. Cleaver that does that? It's one of the physicians here that, when given a lecture, talked to us about his mission trips. And so, I mean, that's some good wilderness medicine they're getting out too. So as far as a breakdown of where some of these surveys show that people are doing practice, current employed versus clinical practice, and what kind of employers we have. So this AFP survey, once again, we take surveys with a grain of salt, how much people actually participate, but states that about 88% of family physicians are practicing full-time, 11% part-time. I'm considered part-time. I don't work Mondays. I did that after my third child just to have more time with home, and so it works out good. And so as far as the average time spent in various tasks, we have clinical practice, patient care task, about 83% is what this survey says. Administrative managerial task, 11%. I think I spend more than 11% of my time at my computer. So once again, I don't think that's pretty accurate. I would definitely say more like a 40-60 because we spend a lot of time at the computer. Teaching, about 5% of people will rate that they're teaching. That could be just having students down in their practice too, teaching versus teaching lectures and stuff. As far as the role in ownership, the survey showed that about 11% of people were sole owners of their practice. And then partial owners or shareholders, if you have like maybe 2 people in a practice or 3, 15%, but 71% of people employed. So as I said, that is definitely the more route that people are going, except for now that direct primary care is taking a large effect. You're going to see those numbers shift a little. This is a breakdown of family medicine practice as far as the primary employer. Once again, self-employed or practice owner or a contract worker, stating about 18% of people will go into this. A single or multi-specialty group, about 21%. University-owned, like University of Missouri, they have about 8, not them specifically, but about 8% of people going into that. Private or non-for-profit hospital or clinic, about 8%. Or private nonprofit hospital or health system, 29%. Managed care organizations or insurance company is pretty low, but there are % of physicians that go out and they just work with actually the insurance people, approving MRIs or whatever. Locums and tenens is pretty small, 1%, and then I don't know what they consider other. But this just kind of breaks that down again as well. As far as the number of office visits people are seeing for an owner versus employed. This one's showing that people who are running a private practice tend to have to see more patients in order to meet their costs versus employed, about 79 per week. And then a lot of people, still do nursing home, but not that many. House calls. I don't know many people who actually do house calls anymore. So moving on to reimbursement, breakdown by either the type of employment, the region that you're in makes a big difference on how much you're reimbursed as a family physician, as well as your bonus structures. Bonus structures can be anywhere from $5,000, $10,000, even up to $20,000 per year, but based on whatever their structure is set up as. This is one of the surveys that shows of all respondents, the mean average was about $209,000 that family physicians were making. But then they kind of break this down to whether you were an owner or you were employed. And some of these conflict with some of the other surveys that you see. And then whether you're owned by a hospital, is a little bit more than the mean. And then solo practice versus a larger group practice. And here it kind of insinuates there is like that medium group practice actually making a little bit more than a larger group. 7 or fewer years in residency. Okay, you don't start out making the most, right? Okay, so about 180,000 there. More than 7 years, 221. So each year, you usually get a bit of a increase in your salary. This breaks it down by regions. Northeast, about 226, but then you could see out west, 242. So it really can vary where you go and practice. So a lot of times the Midwest, most of the surveys will show that the Midwest is the highest paying area, which is great because it's also lower cost of living than California or New York. So it benefits us great. And then, of course, I mentioned this already, bonus structures play a big part. They base bonuses off of many different things. It might be your quality metrics. It might be if you're appropriately billing and coding, and they monitor that. Peer reviews, accuracy of charting. There's a lot of different things. For us, the four are, we have to give a couple lectures to our medical group a year, and then we have to meet certain quality measures, and then we have to get good patient satisfaction surveys, so be nice to your patients. I can't think of what the fourth one is. I don't base my salary on my bonus. If I get it, I get it. If I don't, I don't. As far as healthcare payment models, this is kind of a new topic here, that there's a lot of different ways that medical systems work their payment models and how you're going to be reimbursed. Fee-for-service, value-based medicine, capitation, we're going to go into each one of these. Episode-based and bundled payment, shared savings, payment, pay for performance, and retainer-based practice. So each practice that you look into is going to have a different way in how they're actually billing and their fees. So fee-for-service, the basis of this is payment is per service unit, usually following a service or the descriptions, and so you kind of have what we call level 1, 2, 3, 4 visit, a new patient or returning patient, as well as any kind of special procedure codes that you give. This is how we do it right now down in Macon, and I think many people do it this way. And the providers are basically paid volume and complexity of services that they provide. So, I mean, your salary is, but this is how the group itself collects the money based on that. The problem is the higher intensity care does not necessarily result in higher quality care. So you can have somebody come in for a cough or cold, and if you click all these buttons in your EMR for a simple cough and cold, you might bill higher, but that doesn't mean that the patient actually got any better quality of care. So they have found a lot of, faults to this form of payment, and so they are really looking to move this model away. Value-based medicine, they look at clinical qualities such as are your diabetics getting their eye exams and different things like that, as well as measures of efficiency base of the total cost of care, including some non-physician services. And this is where CMS is talking about leaning towards for 2019. I have no idea what my hospital is looking at, though, because once again, I'm employed. I walk into work and I go home, and if they tell me to change something, I'll change something. But, capitation, this is a fixed amount of money per patient unit of time. And so I don't personally know anybody that uses it this way, but it's basically a lump sum regardless of how many services the patient receives. So they just have a lump sum of no matter what you do that you get. The rates can vary in each region for this because of just the costs. Episode-based bundled payments. So this kind of started back in the 80s where they were paying hospitals a certain bundled service that you may have. One of the large groups that I know that gets this is orthopedics. They're like, okay, you're coming in for a total hip. This is how much we're going to pay you no matter what happens, and then send the patient home, and that's what you're getting paid. So there's a lot of good to this, but there's a lot of bad to this. They say that approximately 1/3 of all healthcare reimbursement were using bundle payments in 2012. Thought that it would help reduce costs of healthcare, as well as paid on the basis of expected costs, but we know that a lot can happen. A total hip can be straightforward, or a total hip can result in an MI and a urinary tract infection with a bed sore because they couldn't get up, whatever. But you're just going to get the one cost if they're there for 2 days or if they're there for 10 days. One of the things that I've noticed with this is all of a sudden orthopedics are kicking them out after, I don't mean to, this is just the one I know a little bit more about, but kicking them out after 2 days of a major surgery, and then they have to go home and rehab, but then it's only 2 days in the hospital for the same amount that they're going to get paid, whether they were 3, 7, whatever. It's kind of a middle ground between the prior two, though, that we were talking about. Shared savings, this is a basis of payment per time period or episode of care. It encourages the creation of it was encouraging the creation of the Accountable Care Act, so we hear a lot of medical terms. ACO is the Accountable Care Act. It's a concept of a healthcare system that reduces total healthcare spending for patients based on how much time a provider is able to spend with them and whatnot. The problem is people who are, it rewards higher spenders than higher performers, okay? So let's just say that you were that physician out there and everybody that came in, they got x-rays, they got lab work, and they got this, that, and this, a real high cost, okay? And then you go to this method and they want you to reduce those costs. So then you kind of maybe stop ordering so many tests, you reduce the cost. You're gonna actually benefit temporarily as a physician from that, but eventually you level out and there is no benefit to it. But it was rewarding these higher cost physicians because they were getting the difference that was made up. So this is not really a great method. And then pay for performance. This basis of payment can vary widely. Rate of payment is variable depending on a lot of different modifiers that might be in effect. Providers on a bonus healthcare that they may meet or exceed quality performance measures. For example, you getting all your diabetics A1C below a certain amount, okay? Then you will get reimbursed better. So I was in a grocery store and my patient ran down a different aisle because she saw me. Later told me she was getting cookie dough because she was depressed and she ate the whole thing of raw cookie dough. Well, I'm never going to get her A1C under order unless I take her grocery shopping every week and feed her, okay? So there's a problem with this system as well. But that is definitely one that they are trying to do where you're based on how well you're able to get your patients under control with different conditions. Let me check how we're doing on time. Okay, we'll speed it up a little bit. Retainer-based practice is the direct primary care where you're basically collecting a retainer from a patient. So you kind of have that set amount of whatever you've decided on. And then many larger practices are merging to become affiliated with larger entities. And so like our practice has gone into an agreement with Boone Hospital, and that helps us buy in with certain things and get better insurance rates and stuff like that. So a lot of groups are doing that to help get some of these different payment models and get the best rates. There are two different models out there. Patient-centered medical homes, you guys probably learn a lot about that. I think a lot of our practices have gone to this. The idea is to help reduce costs as well as accountable care organizations, ACOs. Those are kind of the two recently expanding practice organization models that we hope can help reduce costs as well as give better patient care. Patient-centered medical home is the way we operate in our office. We want to focus more on results than the volume of the patients. We want to make sure that we're giving them and following through with all their care. This was first proposed in 2007 by multiple different groups to move to this practice. And the main thing is coordination with quality health professionals. And so you are the go-to. You should have every single record from cardiologists, from the orthopedics, whoever, so that you can be that primary person for your patients to come to, and you should be able to help organize all that care. Before patients really get lost and they're here, they're there, they don't really know, well, when was your last A1C? I don't know, I saw endocrine for my thyroid and they took care of my A1C, but then I came to my family doctor who took care of my A1C. And you just kind of get this, untied, medical care for patients. So that is the idea behind that. Similar with an accountable care organization is that getting the coordinated care to avoid unnecessary duplication of things. For instance, my one patient who got her lipid panel checked with her cardiologist, got it checked with another specialist, and then I checked it and didn't realize they had checked it. It's just, that's a high cost when you're doing that multiple times with people. And so these organizations are trying to help coordinate that care. And then the electronic health records, you guys kind of all start on that now, I believe. And so once they were originally introduced in 1991, called patient charting or computerized patient records as well as electronic medical records. We now call them electronic health records, EHR. The goal is basically to ideally reduce the or enhance workflow and access to information and make practice more smooth flowing. As any of us practicing physicians, it also hinders us in many ways. You have to, learn how to integrate this in your clinic to where you are able to talk with your patient and document and make them feel like you're there with them. A lot of people are moving to scribes where they have somebody that sits there and just does all their documentation for them as a physician does the work. I can guarantee you at a place like mine, my CEO is not going to pay for somebody extra to have a scribe. I will never have a scribe in my office, but a lot of people are moving to that way and say it's a lot better as far as documentation, having that personal care. But that is one of the things about EHRs is just that block that you kind of get. But it is so nice to be able to, for instance, an A1C, when I have a patient come in, I can click on their A1C and I could look at their trends. I can print them a graph of their weights, whatever. You cannot do that with paper charts. So there's a lot of benefits to the electronic health records, but a lot of downfalls. Productivity, it's supposedly supposed to help with productivity more on the front staff side with scheduling patients, pulling charts and stuff like that. For us, there's a lot more work, but improved billing and coding, a lot of the systems are set up based on where you enter your data, that it gives you a bill code for that office visit, and you don't have to sit there and try and figure out, well, what level was this visit. As far as quality care improvement, they help you to track a lot of your quality care. Are you getting the diabetic foot exams done and the yearly retinopathy, checks and stuff like that? EHRs can, they can follow all that. It also makes it great for research and stuff because they could tap in and just quickly gather data on as long as you're entering into your EHR right. If you're just dictating a single paragraph, then you can't necessarily get all that. But if you're utilizing your EHR, and it just takes time because each one is different. Easier for chronic disease management, as far as determining should somebody be on a statin lowering medication based on, the American Heart Calculator, risk factor. You can have these all built in, and it could pick up what the patient's age is, sex, whether they're a smoker or not, and what their last cholesterol was and their blood pressure, and if they're on meds, and automatically calculate you one of these scores. And you could say, yeah, we really should put you on a statin. And patients, they are, they like to see that data, and you'd be able to show them, you look at your 10-year risk factor of having a major heart attack or a stroke is, 20% if we don't, put you on this. The other thing I like about those type of integrations into your charts is you could click, look, if you quit smoking, that reduces to 8% or whatever it is. And so, you could help encourage patients through a lot of the education that you can get on these charts as well. Quick access to records when things are working right. It's quick access to records. They're still trying to work on integrating all these systems. It's not happened yet. It hopefully will real soon. Being able to tap into Boone or university and be able to get their records and have everything there instead of waiting for, oh, you were in the ER last week at Boone. Let me fax down and get the record release and then fax it back and then me take time to review it. Ideally, it's all at your fingertips now. And then, as I said, improved patient education materials. As far as meaningful use, it's a big word that we've used over time. They're measuring different objectives and looking at different things such as protect patients' health information using security updates and stuff. Electronic prescribing, we're all required to do this now. If you don't meet certain amount of electronic prescribing, then you get dinged on different things. As well as clinical decision support, you have to follow through with certain requirements that they choose for you to do, and then as well as entering your orders through certain ways through the HR. We're all required to do a % of that in order to get reimbursement from Medicare or Medicaid. So how is our time? Because this stuff gets to be meaningful use beyond, if you need to go, let me just see if there's, I think we're pretty much done except for just a couple of those things. And that's my lovely family that I wanted to say that you can have when you're in family medicine. This one was born in my 4th year of medical school. This one was born during residency, 2nd year, and this one was born as an attending. So family medicine is wonderful because you can have a family in family medicine and make it what you want. So these were just some of the resources there. So any questions? Yes?
You said a few times that like direct primary care is increasing in popularity. Do you know why? Or like
Because physicians don't want to deal with insurance and governmental regulations telling us what we need to be doing and submitting. And when you go into direct primary care, you're getting your set amount, whatever you kind of agree to charge a patient, and you don't have to worry with that hassle. It is a hassle, but it's what most people need to have as insurance. Most people can't afford to pay somebody a retainer fee to go be part of their practice. So it's just for a physician, if they can make it happen, they get more time with their patients, they feel less overhead burden and less pressure from things we have to document. Any other questions? All right, well, thank you. I'm close by if you do have questions. And I've had some of the students, when you go into 3rd and 4th year, I'm happy to have you guys down. It's a close rotation site.